Hello student, welcome back to this channel. Today we are going to start with the acute coronary syndrome. Acute coronary syndrome plays very important role in exam and it is one of the most important topic in cardiology, and not just the exam but it is very important in your professional life as well. So let's start with the pathophysiology. Now acute coronary syndrome is mainly due to blockage or reduced blood flow to myocardium, right? So what is the reason behind this reduced blood flow? So there is a atherosclerosis, that is the formation of plaque, right? So first of all we will revise a little bit about the plaque formation. So what are the steps of plaque formation? The first step for plaque formation is endothelial dysfunction, or we can say the damage, right? So there are few factors that are responsible for this endothelial dysfunction, and these are smoking, hypertension, diabetes mellitus, and dyslipidemia, right? So these are the risk factor that is responsible for endothelial dysfunction. Due to this endothelial dysfunction or damage, the LDL will enter in intima. If you remember the structure of artery, you would find that there is a intima, media, and interna. So these are three layers, and due to endothelial dysfunction, LDL will enter in the intima. Now this LDL will oxidize, LDL oxidation. This oxidized LDL act as a pro-inflammatory, and due to this there is a migration of macrophages. This oxidized LDL will act as a pro-inflammatory and it will attract the macrophages so that to clear this LDL and to start healing. But what happens next is, after the recruitment, this macrophage eats this LDL, right? So macrophage plus LDL, we called it as a foam cell, right? So these are few terminals that one should always remember. Macrophage plus LDL is a foam cell. Now what is fatty streak? So it is a accumulation of lesion. So we can say that this whole thing is a fatty streak, right? So this is whole area is a fatty streak. Macrophage plus LDL is a foam cell, right? Up to this situation, everything is reversible. That you can reduce LDL by medication or lifestyle modification, and you can reverse the process of atherosclerosis. But after this, there is some irreversible process and that cannot be reversed. So after the formation of this fatty streak, there is a migration of smooth muscles. Smooth muscle migrate in order to heal. After smooth muscle migration, there is a formation of fibrous cap. See, so this is the fibrous cap which is formed due to the smooth muscle migration. You can see these are the smooth muscles that are being migrated to intima, right? After this, there is a necrotic lipid core formation. Necrotic core lipid formation. What do you mean by this? Foam cell dies. So what are the remainings? There is only lipid and fibrous cap. Now there are two types of plaque that we get in atherosclerosis. The first one is vulnerable plaque and the second one is non-vulnerable plaque. What do you mean by vulnerable plaque? In vulnerable plaque, there is a thin fibrous cap and there is a large lipid core and high inflammation. On the other hand, stable plaque has a thick fibrous cap and smaller lipid core. Let's understand with the cut section. Suppose this is your artery and this is your thin fibrous cap and this is your large lipid, right? So this is your large lipid and this is your thin fibrous cap. So this is vulnerable and this is the cut section of stable plaque. So it has a thick fibrous cap, right, and small lipid core. Now what happens if this fibrous cap break? So vulnerable plaque is more prone for rupture. If there is a rupture, there is a high chance that after rupture there will be the platelet aggregation, right? So due to this platelet aggregation, there will be the thrombus formation, right? And after thrombus formation, there will be obstruction or there will be the reduced blood flow to myocardium, right? On the other hand, non-vulnerable plaque will have decreased diameter of lumen, right? And since it has a large or thick cap, there is a less chance that this will break. So this will result into chronic narrowing, and vulnerable will be in the acute condition, like it will be the thrombus formation. Done. So this is about the atherosclerotic plaque formation. Now what are the markers that are associated with atherosclerosis? The first one is high sensitivity CRP. It is the best single test to detect CAD. If it is positive, then it is a predictor of future CAD. Okay. So this is the first test. The second one is increase total cholesterol. The third one is high lipoprotein A and B ratio. So this ratio is also a predictor of future CAD. Now there is one thing like homocystinemia. Homocystinemia. What we get in homocystinemia is it is an autosomal recessive disease, and in this case there is a high homocysteine in blood which increase atherosclerosis. In such type of patient, we usually start this patient on vitamin B6, 9 and 12, right? So it is important to remember that homocystinemia is autosomal recessive and it accelerates the atherosclerosis. Now there is one ratio that we usually get in our blood reports, and it is possible that you have came across this report frequently, and that is high LDL and low HDL. As we know, HDL is a good cholesterol, right? And the LDL is bad cholesterol. So LDL is associated with high risk of atherosclerosis, right? And HDL in low quantity associated with high atherosclerosis. Now there are few radiological investigation that are useful to diagnose atherosclerosis, and those are, the first one is coronary angiography, the second one is CT angio, and the third one is intravascular ultrasound, right? Coronary angiography is done through radial or femoral artery. So this is more invasive than in cath lab, while this CT angio is less invasive, but it uses contrast. So this is an image of CT angio. Here you can detect any atherosclerosis or any occlusion to the artery. So this is all about the atherosclerosis. Now let's move to risk factors. So what are the risk factors that are associated with the ACS? Now this is important thing in terms of ACS. There are few factors that are modifiable and few are non-modifiable. So what are the non-modifiable risk factors that we can think of? The first one is male. So male are more prone for a ACS. Then age factor, age more than 40 to 50 years are more prone for ACS. Then family history. Now what are modifiable factors? The first one is smoking. The smoking is responsible for endothelial dysfunction, or you can say injury. It causes endothelial injury, so it accelerates the atherosclerosis event. Second one is physical inactivity. So people who are very inactive in physical strength, they are more prone for ACS, and this is a modifiable. Now third is the hyperlipidemia. As we said, high sensitivity CRP, high LDL and low HDL. Then the fourth one is hypertension. So what hypertension does to arteries is that it will alter blood vessels. Also it causes endothelial dysfunction. Fifth one is diabetes mellitus and obesity. So these are the risk factors that are associated with ACS. Now let's study the clinical features of ACS. What are the clinical features that we can expect in ACS patient? Is patient may be complaining of retrosternal central chest pain. So he will present in the emergency or in your OPD saying that, sir, my chest is just tearing apart. So the typical character of this pain is crushing, squeezing, or it can be heaviness. The duration is mostly more than 20 minutes. What about the radiation? You must know the radiation towards jaw, left limb, back, and epigastrium. These all symptoms may be associated with the sympathetic activation. So what are the sympathetic activation? Sympathetic symptoms like sweating, nausea, vomiting, palpitation, anxiety. So these are associated with these above clinical features. Patient might be complain of syncope, dyspnea, tiredness. So these are the typical clinical features. So patient will be present to you with complaining of severe chest pain that is crushing in nature, and he might have some radiation of that pain towards his left upper limb, jaw and back, and epigastric pain, and patient might be sweating a lot with the palpitation and syncope history. So these are the clinical features that are typically present in ACS. But there are few conditions that are associated with minimal clinical features or minimal complaints, like patient with the diabetes mellitus, or you can say the old patient will present it to you with the very minimal complaints, and they will just say that, sir, there is a slight chest heaviness, or there will be the history of dizziness. It might present with the blackouts. So in this type of patient, we have to rule out ACS with the help of ECG and cardiac markers. So these are the clinical features. Now, what are the elements of ACS that we get in this horizon? So ACS consisting of three things. The first one is STEMI. The second one is NSTEMI. And the third one is unstable angina. In STEMI, we will get ST elevation. As soon as we get ST elevation, there is no need to confirm ACS with troponin. Though we can use troponin as a severity of ACS, but there is no need to confirm the ACS in STEMI, right? In NSTEMI, there is no ST elevation. But there are a few ECG changes that we can consider the possibility of ACS, like tall T wave or inverted T wave. Okay, so in this case, we will do the cardiac biomarkers like tropi. Then there is unstable angina. In unstable angina, we have three subtypes. The first one is rest angina. The second one is new onset angina. And the third one is increasing angina. We also call increasing angina as a crescendo angina. So let's understand what each angina means. The rest angina is there is a chest pain more than 20 minutes and it occurs in rest. In new onset angina, there is no prior history and there is a marked limitation of ordinary physical activity, right? What about the increasing angina? So there is a prior history and there is a worsening of angina, right? So these are the types of unstable angina. Now there are few things like stable angina. What is a stable angina? So it is angina after strenuous work and it is relieved after rest, and this is not the part of ACS. We will cover STEMI and NSTEMI in later videos. First, we will be focusing on this unstable angina. So as we said, these are the types of angina, that is unstable angina. This unstable angina gives very good response for sublingual NTG or oral NTG. Then what are the investigation that we can do in this unstable angina? The first one, we will do ECG, and ECG might be inconclusive, right? So we also go for tropis, that is a biomarkers, and these biomarkers are negative. The third one is echo to find out whether there is any hypokinesia. Hypokinesia means there is a decreased cardiac activity, or we can say cardiac motion or contractibility at a particular area of heart, right? So these are a few bedside investigation that we can do, but to identify whether there is ischemia or infraction, we need to do few tests. So for the next step in this unstable angina, we do TMT test, so treadmill test. When we do this test, when there is a no active chest pain, patient is stable, no underlying ECG findings like LBB or ST elevations. What are the contraindications of this TMT? We don't perform TMT in aortic stenosis. Also, there is symptoms at rest or in HOCM, hypertrophic obstructive cardiomyopathy. So there is a protocol we called it as a Bruce protocol, where there is a positive treadmill test consisting of 2 mm horizontal or downsloping of ST segment. So if the TMT is positive, then we will go for angiography. For every patient, we can go for an angiography, right? Like any patient coming with the unstable angina, we don't go for angiography. We will sort few patients to establish the need of angiography. Okay. In some cases where patient can't put on exercise, we go for stress echocardiography. So here we administrate dobutamine in low dose, which creates stress over heart, and we perform echo, right? There is also MPS, that is myocardial perfusion scan or scintigraphy. So what are the indication of MPS? The first thing is that the MPS done with the thallium, right? It differentiate between ischemia and infraction. So localized ischemia we can identify with this MPS. So these are few investigations that we can do in unstable angina. Now what are the treatment modalities that we have for unstable angina? The first treatment option that we have is NTG. Unstable angina is always very responsive for NTG. So NTG is the first line drug. Then we can use beta blocker as well as a second line. Then we can use calcium channel blocker. There are few new drugs like fasudil and nicorandil. But as of now, the first line drug for this unstable angina is NTG. Then after investigation, if there is any blockage or obstruction, we go for stenting. Also routine antiplatelet drugs are used in maintenance. The next thing we are going to study is a cardiac biomarkers. So cardiac biomarkers plays very important role for the diagnosis of ACS, because whenever there is a patient with the chest pain and there is a ECG doesn't show ST elevation, or there are few inconclusive ECG patterns, then this biomarkers helps to diagnose ACS. And the most important thing about these biomarkers are the timings, because if you know the timings of these biomarkers, then you can understand the injury to muscles. So this is the table in which we can understand the levels of biomarkers that we get as per the time of injury. The first most important biomarker is high sensitivity troponin. It is the first detectable within the 1 to 3 hours, and it peaks at 12 to 24 hours, and it remains in the blood around 14 days. It is a gold standard and highest sensitivity and specificity for cardiac damage. So how does it helps in practically? So practically, whenever there is a patient and you want to rule out the ACS and the timing of chest pain is more than 3 hours, then the levels of troponin must be high. But if we get the negative troponin, high sensitivity troponin, then this patient can be ruled out with ACS. The next biomarker is contemporary troponin. So before high sensitivity troponin, we used to use contemporary troponin. It takes 3 to 6 hours, and the level that remains in the blood is around 14 days as well. And the peak is at 12 to 24 hours. So nowadays it has been obsolete. We don't use this contemporary troponin anymore. We usually use high sensitivity troponin. Now suppose if the patient comes to you having the chest pain and you did the ECG and biomarkers, and the biomarkers of high sensitivity troponin is positive, and after 2 days The same patient again complains of chest pain. So in this condition, how would you diagnose the reinfraction? Because the troponin will stay elevated for 7 to 14 days. So now CKMB plays important role in this condition, CKMB. So usually it starts with its level at 4 to 6 hours and it remains for 1 day and it returns back after 2 to 3 days. So to detect the reinfraction in a second heart attack, we use this CKMB. Now what about the myoglobin? So myoglobin is the earliest biomarker that we get in ACS. So 1 to 2 hours and it remains elevated for 6 to 9 hours and it goes after 20 hours, 24 hours. But it is very non-specific for ACS, might be increase in skeletal injury. So these are the biomarkers that we should understand and we should remember to diagnose ACS. In NEET PG, they can put a graph in which they will be giving you a trend and they will ask which biomarker can represent this trend. So you need to understand about the specific timings for this particular biomarkers to make that question right.